Hello friends, welcome to Unacademy. Let's crack NEET PG. I'm Dr. Shonali Chandra, and in this video I shall be discussing the FMGE December 2020 OBGY recall questions. I have highlighted my reference code here, which is SHONELI. So if you take the Unacademy platform and you use the subscription code, you can avail a 10% discount on your subscription package, guys. You can also download the Unacademy learning app, help get notified with the upcoming classes as well. You'll get daily live classes on the platform where you can chat with your educator, ask your doubts and queries, and it's like a live classroom experience. The courses are structured keeping in line with the latest NEET PG syllabus. There are also live tests and quizzes on the platform which will help you evaluate your performance as you go along. And most importantly, one-time subscription gives you an unlimited access, so you can watch all the live sessions from all the faculties who are active on the platform. And even if you miss out on the live sessions, you can always go back and watch the recorded versions from the comfort of your own devices. Top educators are associated with the platform. All 19 subjects which we need to prepare for our postgrad entrance examination, they're covered. And every now and then comprehensive batch courses as well as short duration crash courses, they keep getting launched. So you can check out the ongoing courses in the platform as well. And there's another module of subscription, which is the iconic subscription, which helps you access Unacademy and Prep Ladder at the same time. So this is a new subscription which you can subscribe to for 12 months, 18, 24, or 36 months duration. And if you subscribe using my code, that is SHONALI, then you can avail another 10% discount on your subscription package as well. And talking about the NEET PG Plus subscription, well, you can take one depending on your needs and requirements. So if you're targeting the upcoming exams and want a crash course, a shorter duration course, you can take the 1 month or 3 month subscription. And for example, if you're targeting the next exam, you can take the 12-month subscription. It turns out to be more economical in the longer run. And of course, it gives you ample time to go through all of the sessions and leave you enough time in the end to revise as well. And if you still want a slower pace of preparation, you're in your third year or final year MBBS, then you can take the 24 months duration subscription package. It turns out to be far more economical in the longer run. And if you subscribe using my code, that is SHONALI, then you can avail another 10% discount on your subscription package as well. You can also find me on the Plus platform taking free special live classes. So you can check out the free live classes on the platform as well. Once you subscribe to the package, you will be able to access the capsule courses which are there on the platform. So there is a capsule course in reproductive gynecology, on high risk pregnancy, on gyne-oncology, as well as on labor and its complications as well. So for that, you'll have to become a Plus subscriber as well. So now coming back to the session at hand, this is a video based discussion, guys. So we can, go ahead and without wasting any further time, let's see what kind of questions were asked in the most recent FMGE December 2020 examination. I would say that there were, yes, clinical oriented questions. So that was a good thing, right? And the other thing that was seen was not a lot of controversial questions, one or two here and there. But other than that, most of the examination questions were simple. And if you had a clinical and conceptual understanding of the subject, you should have breezed through the examination. So let's see the first question here. So a woman comes with the complaint of secondary amenorrhea and she has history of recent curatages. Now that's your clue number one here for abortion. Her serum FSH levels are 7 international units per liter. That's your second clue here. What is the most likely diagnosis? So you had to know what these serum FSH levels were telling you, and you had to understand that they were providing you a very significant clue here that there is history of recent curatages, making you think in terms of Asherman syndrome, possibility of fibrosis and scarring of the endometrial lining, right? Now, these serum FSH levels are normal, right? So normal are anywhere between 5 to 20 international units per liter. Okay, so FSH level 7 international units per liter is normal. So if had it been pituitary failure, right, your FSH levels would have been low. Had it been pregnancy, in pregnancy the placenta secretes large amounts of progesterone and the hypothalamus pituitary ovarian axis is suppressed in pregnancy also, your FSH levels are low. And had it been ovarian failure, then your FSH levels would have been high. right? Because of ovarian failure, there would have been an estradiol deficiency, and that would have led to a feedback stimulation of the pituitary, and your FSH would have been high. So the fact that her FSH levels are normal and this clue in the history that there is a history of recent uterine curettage goes in favor of the diagnosis of uterine synechia, because in this situation your hormone levels are not problematic, right? So your pituitary production of hormones, your ovarian production of hormones is normal. What is the problem is at the level of the uterus, where your endometrium is not only building up because she has had fibrosis inside the endometrial cavity. That is what it's referring to by uterine synechia leading to secondary epiduria. Now let's have a look at the next question. Identify the type of twins from the diagram shown. So what kind of twins are shown from this diagram is, you can see two twins here, right? And you can appreciate the intertwin membrane, and you can also appreciate that they have their own separate placentas, right? Now what you appreciate also is that each twin is inside its own amniotic sac, and can you see the layer of chorion? Can you see this layer of chorion? Two layers of chorion also intervening in between the amniotic membrane. So therefore, this is a dichorionic, diamniotic type of twin pregnancy. Dichorionic, diamniotic type of twin pregnancy. Right? Now, what would be the other types of twins, right? So you can see here in this diagram also, and I've showed this to you diagram in the other previous sessions as well, that when you have two separate placentas, or you might have a single fused placenta, but the fusion would be just that they're in close proximity together, so they appear fused, and there are no vascular connections in between the two placentas, right? So nonetheless, in both of these situations, there is going to be an intervening layer of chorion in between the amniotic layers of the two twins, right? So that would be your clue. That would be a dichorionic, diamniotic type of placenta. Whereas when you have a single fused placenta, in all of these three diagrams here, you have a single fused placenta, and that placenta is shared between the two twins. This is a single fused and shared placenta between the two twins with vascular connections in between the two placentas also, vascular connections between the two twins also. But now focus on the, intertwin membrane here. So in figure number 1 here, you can see that there is an intertwin membrane, but there is no intervening layer of chorion in between. So this is monochorionic, diamniotic type of twins, right? Whereas your monochorionic, monoamniotic type of twins will have no intertwin membrane at all. They will be in the same amniotic sac or amniotic cavity. And your monochorionic, monoamniotic type of twins are becoming conjoint, or they are called as conjoint when they are joined together at one or the other area. In this particular case, they are shown joined at the thorax. I mean, they can be joined at the hips, at the ischium. They could be joined at the head, at the craniopacus, right? So there can be various types of conjoint twins. All in all, yes, these are the rarest type of twins, right? These are the rarest types of twins. And your most common type of twins is the dichorionic, diamniotic type of twins, right? So chorionicity basically refers to placentation, whether or not they are sharing a placenta or whether or not they have two separate placentas, independent placentas for each of the two twins. Now, the same principle can also be used to identify the type of chorionicity based on ultrasound. I mean, ultrasound is the best for diagnosis of chorionicity. And you can appreciate here in this diagram as well, in this figure as well, that this is twin number 1, this is twin number 2, and you can see a single fused developing placenta somewhere here, and you can see a dip of the chorionic tissue in between the intertwin membrane here. So this is what we call as the twin peak sign or the lambda sign, right? And this is seen in the dichorionic, diamniotic type of twins, right? Whereas on the other hand, in figure number B, you can see this is one twin, this is another twin's body. This is the placenta here. And you can see here the intertwin membrane is thin and there is no chorionic tissue or there's no placental tissue dipping in between the intertwin membrane. And this is what we call as the T sign. And this is what is seen in the monochorionic, diamniotic type of twins. So the same principle can be used to diagnose the type of chorionicity on ultrasound. And to detect chorionicity on ultrasound, the best time to perform the ultrasound is between 10 to 14 weeks of gestation. Okay. Now, moving on further, the same kind of principle can also be used during placental examination in twins after delivery. So you can see here that there are two separate placentas. You can see here this is amnion of one twin, amniotic membrane of the other twin, and in between the two amniotic membranes, there is an intervening layer of chorion in between. So this is what we call as dichorionic diamniotic again. And look at the other two diagrams here. Now, this is also a single fused placenta. This is also a single fused placenta. But here in the single fused placenta, you can see a very, very thin intertwin membrane here separating the two sides of the placenta, right? And there is no intervening layer of chorion, which is shown in figure number A here. So figure number B here would be a monochorionic diamniotic type of twin placenta. Twins, right? And figure number C here, you can see that there is no intervening intertwin membrane at all here. So this is monochorionic, monoamniotic type of twins, right? So the same principle used in three different ways can be asked in three different set of diagrams as well. Now moving on to the next question. There's a 23-year-old woman who is seen with a complaint of post-coital bleeding after coitus, after intercourse. The following is seen on pars speculum examination. Of course, a bleeding that is arising from after coitus, you need to examine the cervix. You need to go for the pars speculum examination, like I have told you time and again, that do not miss out on looking at the cervix, right? Now, the lesion bleeds on touch. The likely diagnosis is, and they've given you a figure here. Is it a cervical fibroid? Is it a cervical polyp, or is it a cervical cancer, or is it a hemorrhagic cyst? Now, any of these causes could be responsible. Now, this is not a hemorrhagic cyst. This is a classical, presentation or a classical view of a cervical polyp, right? A fleshy, reddish in color, because it's arising from the endocervical epithelium, which is arising from the endocervical epithelium. This polyp can also arise in the ectocervical epithelium. It doesn't matter. But what is important here is that they are usually small. They're usually seen here around the external os, and they're reddish in color. So this is what is the cervical polyp. They are polypoidal outgrowths of the cervical epithelium. Most of the times they're arising from the endocervical polyp. And since the polyps are very fragile, whenever, if you're doing a speculum examination, or you're doing a digital PV examination, they tend to bleed on touch. And the management is going to be simple. If this is the polyp which is creating problems, you simply remove the polyp. You do a polypectomy for such kind of symptomatic cervical polyp. Now let us also see what other, how does a cervical fibroid looks like. I mean, a cervical fibroid can also lead to postcoital bleeding. How would a cervical cancer look like? That can also lead to postcoital bleeding. Now this is an appearance of a much more fleshy, pale looking, larger polyp that is protruding out from the external os. So actually what has happened is that there must have been a fibroid which actually arose from the uterine muscle here, right? Fibroids are all intramural to begin with. They are smooth muscle tumors of the uterus, and then it is like this is coming out into the mucosa here, submucosal fibroid. So it is coming out into the uterine cavity, and sometimes such kind of fibroids can also come down and descend out of the external os like this, right? So this is what is a fibroid polyp that looks more fleshy in appearance. Okay, more fleshy in appearance. And this is what would the final diagnosis would definitely be, once you remove this polyp, do a polypectomy, send it for histopath. I mean, that will only give you 100% confirmation whether it is a fibroid polyp or whether it is a cervical polyp. And if you look at this diagram here, on the other hand, this is what a cervical cancer looks like. This is what a cervical cancer growth looks like. Now, the growth of cervical cancer can be of varying types. I mean, it can be an exophytic growth, which is just filling the vagina and it has just eaten up the entire cervix. It can be a cauliflower-like of huge growth, or it can be this abnormal area on the cervix, which is looking very unhealthy, which is showing dilated blood vessels, which will also bleed on touch, since this is a cancerous growth. And it will be described as really being very hard to feel, really being very hard to feel, right? And of course it will also bleed on touch, and it will look necrotic, it can look fungating also. And on the other hand, there can be this appearance of the growth on the cervix as well, looking like an ulcerative growth, right? So there can be an ulcerative growth on the cervix as well, and it will look as if the cervix has all been eaten up by the growth. And yes, of course, the final diagnosis whether this is a cervical cancer or not will be based upon taking biopsy from this growth as well. So keep these important physical findings in mind as well. And now that you can see that all of these kind of findings you can find in a woman with postcoital bleeding, depending upon what is the underlying cause of this postcoital bleeding. So if you find a lesion, that lesion has to be biopsied. If you find a polyp, that polyp needs to be removed and again sent for histopathology for final confirmation of what it actually is. Now, moving on to the next question. Now, there's a 14-year-old girl who comes with the complaint of cyclical abdominal pain. She's not attained menarche yet and has normal breast development, right? So again, I told you that primary amenorrhea is a very, very important topic, and they have been asking questions again and again on various clinical presentations of primary amenorrhea. So let's go ahead and read up. Local examination reveals the following findings. What is the likely diagnosis? So if you look at this figure here, and yes, the images are subject to, see, these are recall questions. So I'm not very sure which exact image was there in the question, but yes, what you can see here is that the hymen is still intact. It is not perforated. It is completely blocked. You can't reach the inside of the vagina at all. So there is a membranous covering over the introitus here, which is what we call as imperforate hymen. So this is imperforate hymen, guys. And yes, of course, there can be a bluish bulge. You can see a bluish hue behind this because of collection of blood inside the vagina. Now that has been because there is an outflow tract obstruction. So she is having cyclical abdominal pain. That means she has started menstruating, but there is no outflow to that menstrual fluid. It is all collecting behind, right? So that's why she has not attained menarche yet. That means there's not onset of menses yet, but her pituitary gland, her GnRH secretion, FSHLH secretion are all progressing fine, and that is why her ovaries are also normal, so her breast development is also fine because the estrogen deficiency is not there. The estrogen levels are normal, therefore she is having normal breast development as well. So this is a classical clinical presentation of imperforate hymen, and this complaint of cyclical abdominal bleeding in the face of no visible actual menses is what we call as hidden menses or cryptomenorrhea. Right? Now, in a transverse vaginal septum, the most common location of this transverse vaginal septum is higher up in the vagina. So there's not going to be a very clear-cut finding on the local examination like this that is seen with imperforate hymen, and the local examination is more or less going to be normal. In Mullerian agenesis and androgen insensitivity syndrome, guys, there will be a normal breast development again in both of these clinical situations, but there will not be any history of cyclical abdominal pain or cryptomenorrhea because in both these situations the uterus is absent. Breast development is normal, right? So then there will be no history of cryptomenorrhea. And on the other hand, there is going to be a blind vaginal pouch, right? So it will appear that yes, the vagina is there, but it could just be a blind vaginal pouch, or it could just be a skin dimple there, but it won't show this classical clinical appearance or local examination findings of an imperforate hymen. Now, let's have a look at the next question they asked. Now, woman is seen at 11 weeks of gestation with complaint of mild spotting. find first trimester bleeding. So, of course, you suspect one of the causes being abortions. So, you do an ultrasound, and ultrasound reveals a gestational sac of only 5 weeks gestation with no fetal pool inside. So, it has been 5 weeks of gestation by now. There should be a growing fetus inside, but there is no fetal pool inside. What is the diagnosis? The diagnosis is missed abortion. Missed abortion, right? So, this is an embryonic pregnancy. This is an embryonic pregnancy. There is no embryo inside, right? So what is the diagnosis of missed abortion, or what is the classification or findings of early pregnancy losses that I had discussed with you? Well, whenever there is a gestational sac only and with more than or equal to 25 is the mean sac diameter, and yet it is empty, there is no fetal pole inside, it is called as early pregnancy lost or missed abortion. Or there can be an embryo inside. I mean, there can be an embryo inside the gestational sac with a crown rump length of more than 7 mm, and yet there is no cardiac activity that has come. That would be a missed abortion or an early pregnancy loss. Now, in a threatened abortion, the bleeding is there, the spotting is there, I agree. But on ultrasound, there's only a threat of abortion. Otherwise, the pregnancy is fine. So, in threatened abortion, the USG will show cardiac activity which is there in the fetus, and the fetus is otherwise healthy. And in incomplete abortion, you will have a different clinical profile. You will have a clinical profile where bleeding has started and continued, and there will be more bleeding. And on ultrasound, you will see some products of conception still inside the uterus. And in inevitable abortion, on the other hand, the process of abortion has started, and there is increased amount of bleeding. There is increased amount of pain in the lower abdomen, and there will be, the os will have started to open up. So let us just summarize what these various clinical presentations of abortion can be, because this forms a very, very important and frequently asked question, clinical based question in your examinations, right? So if you look at it here, there can be other types of clinical presentations, like there can be a threatened abortion, or there can be an inevitable abortion, or there can be an incomplete abortion, or there can be a complete abortion on the other hand. So in a threatened abortion, guys, there is going to be a woman in her first trimester. She will come with complaint of some bleeding, spotting, and bleeding is going to be mild. All the contents are still inside the uterus, so your uterine size is going to correspond to the period of gestation, and the process of abortion has not yet started, so your os is going to be closed on clinical examination, and also is going to be closed on ultrasound as well. When you do an ultrasound, you will confirm that the cardiac activity is present, and in this situation, all one needs to do is follow a conservative management and just reassure her and wait and watch. All that is needed is that. I mean, you don't need to do anything significant in a case of threatened abortion. You just need to follow conservative management. But if it's an inevitable abortion, her bleeding PV would be more in amount, right? Your contents are still inside the uterine cavity, so your uterus size is going to correspond to the period of gestation. The products of conception are starting to move out, so your os is going to be open. Your os is going to be open. Now, it is immaterial if you do or do not do an ultrasound. On ultrasound, you can have a fetus with a cardiac activity or not. It doesn't matter. But the fact of the matter remains is that the process of abortion has become inevitable, right? So in this kind of situation, we let the process of abortion progress on its own, and we intervene only and only if she becomes hemodynamically stable, or if she's losing too much of blood. I mean, then we are going to intervene in the process, or we are going to expedite the process of expulsion. What's incomplete abortion, on the other hand, the bleeding PV is going to be significantly more, and depending upon the amount of blood that she has lost, she could be in a state of shock as well. She could be hemodynamically stable as well. And you can see here that half of the part of the products are expelled, and part of the products could be lying inside the vagina, and part of the products are still retained inside the uterine cavity. So your size of the uterus is going to be less as compared to the period of gestation, and your os is going to be open because the products are still passing through. Right. So in this kind of a situation, if a woman is hemodynamically unstable and she's losing a lot of blood, I will need to expedite the procedure. So I will have to base my decision on her hemodynamic status. So I will start with resuscitation, plus I'm going to expedite the process of expulsion. And if she's hemodynamically unstable, losing a lot of blood, I will have to resort to a suction evacuation or a curettage to finish off the process of expulsion faster. And in case of a complete abortion, your woman will come with a classical clinical presentation of having pain abdomen, and there's going to be a significant amount of bleeding that had happened, but it lasted for a couple of hours and then it has stopped. So there is going to be a history of blood loss, which was significant. But now that bleeding must have stopped or must have decreased significantly. There was initially a lot of pain, but now the pain has also stopped, and there could be a history of passage of a fleshy mass from the vagina. That history could be there, and the size of the uterus is going to be considerably less as compared to the period of gestation, because all the products have already been expelled and nothing is inside the uterine cavity, and the os has ended up closing. So your os is also closed. Now in this kind of situation, you can confirm on ultrasound, and on ultrasound you can see that the uterine cavity is going to be empty. There's going to be nothing inside the uterus. And if that is your thing, then if that is your finding, then you don't need to do anything. You just need to go for conservative management, because the process of natural spontaneous abortion had started, got completed, and now there's nothing left inside the uterine cavity. So you don't need to unnecessarily intervene, right? Now, let's see the next question. Now, a woman is planned for suction and evacuation for missed abortion, right? I'm not very sure what was given here, but some contents of fetal tissue are seen on the uterus on ultrasound. During evacuation, the catheter goes deep into the uterus without any resistance. So what has happened? The catheter which you were using to do a suction evacuation, that ended up going deep into the uterus without any resistance. I mean, you kept on introducing the catheter, and you realized that you have introduced this to far greater depth into the uterus without feeling any resistance. So now you're suspecting that probably you have ended up perforating the uterus. So you are suspecting perforation, and that too during evacuation using a suction method. Suction evacuation, right? So what would be your next step? The next step when you perforate with a suction has to be performing an immediate laparoscopy, right? So first of all, you would stop the procedure once you realize that you've ended up perforating the uterus. The immediate thing is that you should stop the procedure. But with suction, if you have performed a perforation with a suction catheter, then you need to explore the pelvis and the abdomen. So that's why performing immediate laparoscopy is what is going to be done. So let's have a look at it here. Like, you could perforate the uterus while using a dilator also. You end up pushing the dilator too inside, and the dilator also goes in without any resistance. Again, you would feel that you've ended up inserting the dilator too deep. Now, the perforations with the dilator, they are usually clean perforations. They are usually clean and small perforations. So what you're going to do is that you're going to take out the dilator. You've ended up putting it in. You're going to take it out. The moment you take it out, you'll realize that there is a gush of blood that comes out. Okay, there's a fresh bleeding that happens. And then what you're going to do is stop the procedure. Further. And then what you're going to do is observe the vitals of the woman. Now, most of the times, this is going to be a clean and small perforation, which is going to seal off on its own by the body's normal coagulation mechanism, and the bleeding will subside and the vitals are going to remain stable. So if her vitals are remaining stable, then as a second point, and after you have ensured that she is hemodynamically stable and there is no bleeding has subsided now, then with the help of a senior consultant, one can, complete the procedure under ultrasound guidance. That is what one can do. But if your vitals are unstable and you become unstable and your bleeding doesn't stop, then one has to resort to a laparoscopy to repair the perforation. Then one has to resort to a laparotomy to repair the perforation. Now, what if you perforate using suction cannula on the other hand? Now, you can see here that this suction cannula is connected to the suction apparatus. It is connected to the suction apparatus, and you're using this suction cannula and you've ended up putting it through and through the uterus. So you realize here that there are holes from which you're suctioning the contents of the uterine cavity. Now, since you will have perforated, you don't know what has gotten entailed in these holes, whether you have damaged some gut, because of the suction energy. So there are more chances of damage to the gut or to the omentum or to the nearby structures, right? So that risk is always there, and therefore when you perforate with a suction cannula, or you perforate with a larger instrument or a broader instrument like curette. Now curette is also hollow here. Curette is also hollow here. So what got lodged in this hole, we don't know, right? So when you perforate during suction with a cannula, suction cannula, or with curette, you always have to explore the pelvis. You always have to explore the abdominal contents, whether some hidden damage is there or no. The fact of the matter remains that if she is stable, if she is hemodynamically stable, one can go ahead and go for a laparoscopic exploration. Laparoscopic exploration of the abdomen and pelvis. And if she is hemodynamically unstable, then the same thing has to be done by a laparotomy. Same thing has to be done by a laparotomy, right? Now, let's have a look at the next question that they asked. Now, the question did not have a figure. The question did not have a figure from what I gather, but I've introduced the figure to help you understand. Now, what is the true conjugate? I told you the most important diameters of the true pelvis, right? And I told you the most important fact about the pelvic inlet. The inlet of the pelvis are the anteroposterior diameters of the inlet. So true conjugate is measured from the upper border of symphysis pubis to the tip of the sacral promontory. This one here. So this is the pubic symphysis, guys. If you remember from my lectures, this diagram here again. So this is the pubic symphysis, guys, symphysis pubis, and this here is your sacral promontory, right? And that is your tip of the sacral promontory. So from the upper border of symphysis pubis to the tip of sacral promontory is your true conjugate, right? Remember that. And from the posterior surface of the pubic symphysis to the tip of the sacral promontory, this one here is your obstetric conjugate, right? This one here, obstetric conjugate. And this one here, the other one here, from the lower border of symphysis pubis to again the tip of the sacral promontory, this one is your diagonal conjugate. This one is your diagonal conjugate, right? Okay, so among all of these three diameters, the smallest is the obstetric conjugate. This is the smallest anteroposterior diameter among the three. And the only diameter which can be clinically determined, which can be clinically estimated on pervaginal examination is your diagonal conjugate. So these are important diameters which you need to remember, right? Now, let us see the next question that they'd asked. Now, the other question that they'd asked was a newborn of a diabetic mother has hypoglycemia after delivery. So the baby has hypoglycemia from a diabetic mother. Mother is diabetic. What is the reason for the hypoglycemia? Another question that I have discussed always in the classes, that it is when the diabetic mother has uncontrolled diabetes, has uncontrolled blood sugar levels. So there is maternal hyperglycemia. There is maternal hyperglycemia, and then glucose freely diffuses from the placenta, from the mother's side to the fetus's side. So there is fetal hyperglycemia as well. Now, to tackle this fetal hyperglycemia, which is happening in the intrauterine life, this is happening when the fetus is still inside the mother's womb. So, fetal hyperglycemia triggers the hyperplasia of the fetal pancreas. Fetal pancreas, they start having beta cell hyperplasias to tackle this hyperglycemia, and that leads to fetal hyperinsulinemia. Fetal hyperinsulinemia, increase in insulin. Right now, this fetal hyperinsulinemia actually leads to fetal fat deposition, making the baby big and macrosomic. That is one thing that it does. The other thing is that this fetal hyperinsulinemia doesn't make the fetus hypoxic. There is no fetus hypoxia. There is no fetus hypoglycemia. Fetus hypoglycemia is not there because fetus is right now getting the blood glucose from the mother. Right, but after birth, what is going to happen when the placenta is not there? No more maternal glucose is getting transported towards the fetal side. Now this fetal beta cell hyperplasia that happened throughout the 9 months of pregnancy is going to subsist for some time. So the newborn will also have increased fetal insulin because of these fetal pancreas, which became beta cell hyperplasia, which happened in the intrauterine life. So that is going to persist, and that leads to hypoglycemia in the newborn after delivery. More chances of hypoglycemia in the newborn after delivery when there is a diabetic mother. That happens because of increase in fetal insulin, and that increase in insulin, that fetal pancreas beta cell hyperplasia, that persists for some time after birth. And that leads to increased insulin in the newborn life as well. And that increase in insulin is responsible. It is not maternal insulin. Please remember, maternal insulin doesn't cross the placenta. So it is not because of increase in maternal insulin, it is because of increase in insulin coming from the fetus itself, coming from the newborn itself. Okay. Now, moving on further, let's have a look at another question they asked from diabetes, again from the notes here as well, again from what we've already discussed. A woman undergoes oral glucose tolerance test at 27 weeks of gestation. Her fasting blood glucose is 130 and 2-hour value is 200. These are grossly deranged values. These are values in the overt range, and ultrasound shows a healthy intrauterine pregnancy with an AFI of 14, an AFI on the higher side, right? But that AFI doesn't matter. What matters here is the fact that your fasting levels and your 2-hour levels are grossly deranged. They are in the overt range. A fasting blood glucose value more than 126 and a 2-hour value which is more than 200. These are in the overt range. So of course one has to start the diet modification, start the exercise therapy, all that will start, but you have to start insulin along with this as well. So you have to start insulin. So there is no reason to repeat oral glucose tolerance test. Okay. The other thing is that how do you start insulin? So you have to see that in pregnancy what is required is a very rigid blood sugar level control, right? When you do a sugar profile in the woman, you have to check the degree of control, and for that you check the fasting levels, you check the 1 hour post meal levels also, you check 2 hour post meals levels also, right? You give morning evening insulin, and then you have to control for all of these levels. And I'm saying post meal, so it is a long sugar profile. Fasting 1 hour 2 hour post breakfast, 1 hour 2 hour post lunch, 1 hour 2 hour post dinner. So 7 samples in a day are required, and it is better done after admitting her in the hospital, because you have to start insulin. To start insulin, you have to titrate how much dosage is required to control control the blood sugar. So that titration requires some trial and error method. So you will start some dose, you will see if it works. If it doesn't, you will increase the dose further, or if you have ended up making her hypoglycemic with your insulin, you will decrease the dose. You will do that titration. Now that can be best done once you admit her. So you admit her, start insulin, set a dose for her. Once she's stable on a particular dosage of insulin, then you can send her home back again. But the first, to arrive at the correct dosage of insulin for that woman, and that specific titration that has to be done for a rigid sugar level control has to be done after admitting her and starting the insulin, right? And this check sugar profile at 34 weeks, monthly sugar profile, no, it has to be done on a daily basis. I mean, even if you have to send the woman home, she does this very frequently, home blood glucose monitoring. I mean, she has to buy a glucometer, and then she has to check her own blood sugar. She has to be taught how to check the blood sugar levels and what to do, how to titrate her own insulin. So that has to be taught to her. So it has to be a more rigorous blood sugar profile monitoring, rather than just doing one random sugar profile again at 34 weeks, or a monthly sugar profile. It has to be much more frequent than that. At least she will do it once, or every alternate day at least at home, and then every weekly follow up in OPD is what she's going to do after you have managed to achieve a glucose control after admitting her. And once you send her back home, she's going to report to the hospital every week at least for follow up. So keep this important point in mind as well. Now, what I am again emphasizing on, that as long as she is GDM, that means the sugars are not in the overt range. That means your fasting is more than 92, but it is less than 126, and your 2R is more than 140, but it is less than 200. As long as it is GDM, right, you can simply go for diet therapy, you can go for exercise, and then you can see her again after 1 week. You can do a sugar profile, like I told you, fasting, 1 hour post meal, 2 hour post meal. So sugar profile is done, right? If she is not controlled, the targets of controlled are that your fasting should be less than 95, your 1 hour should be less than 140, and your 2 hours should be less than 120. This is your control. If it is not controlled, these are your targets for control, right? If she is not controlled even after 1 week, you have to start her on insulin. That is your drug of choice. And if she has overt range of sugars to begin with, then you have to, along with diet and exercise, you also have to start with insulin straight away. Like we just discussed in the explanation of the question. So keep this important differentiating feature in mind as well. Now let's have a look at the next question that they asked. Now there's a 30-year-old young woman who came for a regular checkup, right? So otherwise she's asymptomatic. She's just come for a regular checkup, and she's found to have a 6 by 6 centimeter ovarian cyst. What is the management? Now most of the cysts in young women, in young reproductive age group women, are actually follicular cysts. Most commonly found, I mean, there can be a number of them. Most commonly what are seen are follicular cysts, right? And they are there, they form and they will disappear on their own over a period of time, and she's otherwise asymptomatic. You see this, she doesn't have any symptoms of pain or any menstrual irregularity. Now what is the management? You CA125. Now CA125 is a very good tumor marker for epithelial ovarian cancers, but not in the reproductive age group, in the postmenopausal women, because in the reproductive age group there are many other benign cases also where your CA-125 can be elevated, like they can be found elevated in fibroid uterus also, in endometriosis also, in genital tuberculosis also, in PID as well. So they don't add anything of value. They're not very specific in the reproductive age group. So that is not what is required to be done. Now, whether you do an ovariectomy or not, ovariectomy would be basically a previously used term for cystectomy. So whether or not you would remove this cyst or not, it depends upon the size of the cyst. So the size of the cyst is less than 7 centimeter. It's less than 7 centimeters, so there's no need to do an ovariectomy, right? Now, whether you do it by laparotomy, whether you do by laparoscopy, doesn't matter. You see, it will depend upon the surgeon's expertise, the facilities available, right? So that in turn can also lead to you to, completely rule out these two options, right? Because you will not do an ovariectomy, right? It doesn't matter laparotomy or laparoscopy. That will depend upon the surgeon's expertise and the facilities available, right? So that is immaterial, and that's why I can safely rule both of these cannot be correct at the same time. So therefore both of them are wrong, and what is required to be done is just follow up. Actually, the treatment of this situation, management, is simply follow up after 3 or 6 months, usually 3-month follow up, to see if the size has the cyst has disappeared or whether it is increasing in size, right? So follow-up is all that is required. Now, this OCPs which are given, they are not a treatment for the cyst. Please remember that oral contraceptive pills do not lead to the resolution of the cyst, or they are not for treatment of the cyst. I mean, they do prevent future development of cysts or any new cysts for arising, but this cyst is more or less going to disappear on its own or resolve on its own. So they're not a treatment per se, right? In this particular cases, that's the only option given. I will go ahead with that. The treatment here is follow-up. The management here is follow-up. OC pills probably are used since she's a 30-year-old young woman. Maybe she needs contraception as well, so that's why. Other than that, OC pills by themselves, they do not lead to the resolution of the cyst. They do, yes, help prevent in development of new occurrence of cysts. So that's your best choice of answer here. That is option number D. Now let's have a look at the next question that they had asked. Now there's a young woman who is being evaluated for infertility. Okay. On pelvic examination, the uterus is retroverted. Uterus is pushed back to retroverted. Okay. And there is a mass/nodularity felt through the posterior vaginal fornix. So you have the uterus here, which has become retroverted. That's your rectum, that's your vagina, and that is your pouch of Douglas here, and these are your uterosacrals, which also go behind. So when you're doing a PV here, you feel something here, probably a mass, some nodularity in the uterosacrals and pouch of Douglas, plus the fact that the uterus has been pulled back, it has become retroverted. So something is pulling back from the uterus from behind, and I've frequently emphasized on that. These are adhesions. Now, for the fact that she also has infertility, and these deposits, these nodularity of mass that you feel, they are tenderness in the posterior vaginal fornix. So the likely diagnosis is definitely an endometriosis. I mean, the fibroid uterus will have a uterus that is enlarged, irregularly enlarged most of the times, and the classical findings of infertility, retroverted uterus, tenderness in the posterior vaginal fornix, goes in favor of endometriosis. And adenomyosis has a different clinical presentation altogether. It presents mainly in multiparous women with abnormal uterine bleeding, heavy menstrual bleeding, severe congestive dysmenorrhea, and diffusely enlarged globular tender uterus. So a completely different set of findings, and therefore not the answer here. And it's not an ovarian mass, because they are saying that the ovarian mass has to be felt separately from the uterus. It has to be clearly defined. You would be able to feel an ovarian mass clearly separately. And most of these ovarian masses in young women, they are going to be benign, so less likely to be tender also. And why would there be infertility? So simply because of these three factors, I choose the answer that is endometriosis. Okay. Now, moving on further, let's see what else they had asked. Now, what is the contraindication of the contraceptive method shown in the image? Now, what's this contraceptive method? You recognize it as copper T. Okay, this particular copper T is copper T 380A because of the copper sleeves on the arms as well. But irrespective of which type of copper T it is, the contraindication is what? Is it PID? Is it hypertension, diabetes, or breastfeeding? Well, the answer is PID. Now, copper T does not contain any hormones. Well, hypertension is not a contraindication for copper T. Copper T does not cause hypertension, neither does it worsen it, neither does it increase it. So, hypertensive women can safely use the non-hormonal, this is a non-hormonal method of contraception, right? And diabetes, yes, again, since there are no hormones, one safely can be used in diabetes as well. It's not a contraindication. Breastfeeding, again, it's a non-hormonal method, therefore absolutely safe in breastfeeding lactating women as well. But yes, PID, pelvic inflammatory disease, if it is there, current PID, not past PID, let me again remind you, current PID right now, while inserting the copper T, if the woman already has an active genital tract infection or PID, what will happen is that you can worsen or flare up the PID, because see, you're going to introduce it from outside, so your infective agent can ascend on the copper T from the cervical up into the uterine cavity as well. So current PID, active genital tract infection, that is a contraindication for this copper T, not hypertension, diabetes, or breastfeeding. Okay. Now, let's have a look at the next question that they asked. Which contraceptive method is contraindicated in lactating women? Well, I've told you time and again that yes, it is the oral contraceptive pills, the combined hormonal contraceptive pills, which are absolutely contraindicated in lactating women. So, if a woman is breastfeeding, and she is less than 6 months, it is an absolute contraindication for oral contraceptive pills, because oral contraceptive pills, they are thought they interfere with the quantity and quality of milk production. Okay. And if she is not breastfeeding, what then? If she is not breastfeeding, can she use oral contraceptive pills? No. Even then, if she is less than 6 weeks, then also oral contraceptive pills are absolutely contraindicated, because oral contraceptive pills, they also lead to increase in clotting factors, and they also contribute to the increased risk of venous thromboembolism. And in the postpartum period also, there is an increased risk of thrombosis and thromboembolism. Risk is there, right? Pregnancy is a hypercoagulable state, and this hypercoagulable state persists for some time in the postpartum period also, till your clotting factors all come back to normal levels, right? So that's why it's not advisable to use oral contraceptive pills in lactating women at all, right? On the other hand, your progesterone based methods, your progesterone only contraceptive methods, be it PO pills, they can be started anytime after delivery. They can be started soon after delivery as well, right? So they are safe because they don't have estrogen. Your DMPA, they can also be started, they're also safe in lactation, but they can be started after 6 weeks of delivery. They can be started after 6 weeks of delivery, right? If you talk about intrauterine devices, well, both copper T and Mirena, which is Mirena is a levonorgestrel containing IUD, both can be given freely in lactating women as well. So your IUDs, you can insert them within 48 hours of delivery. If you miss this opportunity of inserting within 48 hours of delivery, then we have to give it after 6 weeks, after 4 weeks to be very precise. But usually the visit is the postnatal visit is postpartum visit at 6 weeks. So anytime after 6 weeks, it's perfectly fine to insert copper T or Mirena in a lactating woman, right? Now, let's have a look at the next image-based question they had asked. Now, what is the mode of insertion of the device shown in the figure? I'm not sure if this particular same picture was there, but there was a coiled device which was shown inside the fallopian tube. Now, if there's a coiled device inside the fallopian tube, the best way to reach the fallopian tube is via the hysteroscope, right? You can insert this coiled device into the fallopian tube. This is what is called as hysteroscopic ligation, hysteroscopic tubal ligation, where these coiled tubes, they are introduced hysteroscopically. So the mode of insertion is hysteroscopically into the fallopian tubes, and there these coiled tubes, once placed inside the fallopian tubes, would trigger an inflammatory response and will eventually lead to a blockage of the tubes. Now that blockage will not be immediate. That blockage usually takes 2 weeks time. The blockage usually takes 3 months time. 3 months time for tubal blockage to become effective, and therefore one has to use additional contraceptive method during these 3 months after the hysteroscopic tubal ligation, and you have to confirm whether or not this method has worked. After 3 months, one has to go for a HSG. After 3 months, one needs to perform a hysterosalpingography to confirm tubal blockage. And in the meanwhile, in these 3 months, the woman is supposed to use some other method of contraception as well. So these are important points to note about this mode of insertion of the device, right? This is a hysteroscopic tubal ligation method, and the mode of insertion is hysteroscopically, not by laparotomy, not by laparoscopy, not from the uterus side it is inserted, not from the fimbrial side. If you think you can do it the other way around, no. Okay. Now, moving on, let's have a look at the next question that they asked. Now, a woman is seen after hysterectomy. A woman is seen, let's say, post-operatively after hysterectomy, and she has a distended abdomen. Now, what electrolyte imbalance is likely seen in this case? Now, this question is more of a surgery question rather than an ops question if I look at the options, because this is a complication that can happen after any abdominal pelvic surgery. After any surgery, this complication can happen, which can happen to lead to a distended abdomen. Now, what is this complication that is happening? In this particular case, where there is gaseous distension of abdomen and an electrolyte imbalance is responsible for it, is what we call as paralytic ileus. Paralytic ileus. And if you look at the causes of distended abdomen post surgery, if you look at the causes of distended abdomen post surgery, there can be n number of causes. Let me just highlight the important ones here for you. So there can be collection of blood. There can be collection of blood bleeding inside the peritoneal cavity. Maybe you've ligated a bleeder, you've ligated a pedicle, and that suture slipped or something, or there is some bleeder that you had failed to identify during surgery, left it there and had bled after that. So in that situation, a woman is going to become pale. She's going to look pale. She will probably go into shock. She will have features of tachycardia because she's losing blood inside the peritoneal cavity. So those additional features will be there, and that would cause distended abdomen post surgery, and that fluid distension will be there, right? And then of course there can be gaseous distension as well. Gaseous distension, right? Now this gaseous distension can be because of the gas that is retained inside the gut, because the gut is not able to pass the flatus, right? So that can happen with paralytic ileus. Or there can be another cause of this gaseous distension, could be intestinal obstruction. Now, intestinal obstruction would become a very serious complication after after any abdominal or pelvic surgery. If you've ended up traumatizing the intestine, or you've caused the intestinal obstruction, then that can also, or you've tied a suture accidentally around some small part of the gut, and that is leading to intestinal obstruction. So again, that would have a gaseous distension as well. But paralytic ileus usually presents within 48 to 72 hours post surgery, and your intestinal obstruction is usually a late complication, about 5 to 7 days post surgery it presents. And intestinal obstruction will have other associated features of nausea, vomiting, will have fever, or other symptoms of peritonitis as well might be there. So that is one thing. So these are broadly which I wanted to specify in front of you, some causes of distended abdomen post any abdominal or pelvic surgery. And paralytic ileus in particular is caused also by hypokalemia, or electrolyte imbalance, hypokalemia. Right? So potassium is responsible for the motility of the gut. So it's a smooth muscle. The gut muscles are smooth muscles, right? So those motility is dependent upon potassium ion. So if there's hypokalemia, that can also lead to reduced intestinal tract motility, contributing to paralytic ileus. And this condition responds with the paralytic ileus. This condition is going to respond to conservative management measures, like you can go for a NG tube, placement of an NG tube to deflate the gaseous distension of the abdomen, so that can be done, and you will treat the electrolyte imbalances. That will be done. So conservative management, though there's no need to go for a reopening the case, or resorting to severe surgical measures to treat a paralytic ileus. So medical treatment in terms of just putting a nasogastric tube for the gas to pass out, and for the electrolyte imbalance correction is all that is required for this situation. Now let's have a look at the next question that they ask. Now, which of the following, which is the most dependent part of a sitting woman? Now, plain and simple question can be answered with simple anatomy. So many times I have shown you the sagittal section diagrams of the pelvis. So many times I talk about the pouch of Douglas, pouch of Douglas, pouch of Douglas. We've talked about how in ectopic pregnancy rupture fluid collects in the pouch of Douglas, right? So if you have a sitting woman or a standing woman, basically an upright person, basically in the upright position, okay, whether sitting or standing, the most dependent part is the pouch of Douglas. Now, what are these other parts? So going back to our anatomy lectures, anatomy days, look at this here. These are the peritoneal reflections which are seen on this sagittal section of the abdomen and pelvis. So this is your pouch of Douglas. That's your most dependent area. This is your pouch of Douglas, right? The peritoneal reflection that is between the rectum posteriorly, the lower part of the cervix posteriorly, and the uterus. This is your pouch of Douglas. That's your most dependent portion. Any ascites, any collection of pus, any collection of blood fluid goes here into the pouch of Douglas first. That's your most dependent portion. And you can imagine if the woman is standing, like in this particular case, or even if she's sitting, but as long as she's upright, walking, it is in the pouch of Douglas. And then you have all these other areas of the pelvis. You have an area here, subhepatic recess, and this area here, beneath the posteriorly, beneath the liver, beneath the liver here, this is your subhepatic space. This is your Morrison's pouch, right? This is your Morrison's pouch, and that's also called as your hepatorenal pouch, right? And then you have this area of the paracolic gutters. You have the paracolic gutters also. So Morrison's pouch or hepatorenal pouch is the most common space where fluid or blood collects inside the peritoneal cavity if you were to make this woman lie down, or make this man lie down also for that matter. Right? If any person lies down, the most dependent part, imagine the most dependent part, this person lying down, this becomes your most dependent part. This is your most dependent part in the supine position, right? So these are two important anatomical points, questions, anatomy. And again, yes, pouch of Douglas have shown you in so many sagittal sections of the female pelvis so many times. Now let's have a look at the next image that they asked. So they'd asked you to identify the image. What can we see in the image? We can see that a cannula is inserted through the cervix. We can see this dye. We have pushed in a dye and taken a X-ray film. So we are doing hysterosalpingography. We can see the dye filling the uterus completely, no problem there. We can see the dye moving into the fallopian tubes, no problem there. But we can see that the distal ends of the fallopian tubes are all convoluted and dilated. There's a collection of dye in the distal tubal ends, and there is no dye coming out from, no shower like sprouting of the dye coming out from the distal tubal ends or coming out from the fimbrial ends. So this is a distal tubal block. This is a distal tubal block. Now the cause of this distal tubal block is basically tubal damage. Now this tubal damage could have been because of PID. This tubal damage could have been because of tuberculosis or any other factor. It could be an external, pelvic adhesions in the pelvis which are blocking the fallopian tubes. Anything, it could be. Most of the times it would be because of PID and genital tuberculosis. But what happens is that this could be collection of anything inside. This could be empty, hollow, just hollow dilated tubes, thickened tubes, or this could be pus inside the fallopian tubes that has been collected inside. This could be simply be hydrosalpinx. Most of the times it is a hydrosalpinx. So from what I think that the options that were provided in your question mentioned bilateral hydrosalpinx. But what I want you to understand here is that yes, the other options were less likely. What I want you to understand here is that yes, of course, bilateral hydrosalpinx could be there, but anything could be there inside the swollen and distended tube. It could be pus also, or they could be plain and simple thick and swollen tubes without containing anything inside them. So therefore to come at the right 100% absolute diagnosis and to find the reason for such a distal tubal block, it's such an appearance in HSG, the next step in evaluation is always a laparoscopy. The next step in evaluation is always a laparoscopy, so that I can see evidence of PID. I might see pus coming out of the fimbrial ends of the fallopian tubes. I will be recognizing what is the extent of tubal damage. I might be able to look at miliary tubercles, white dots on the pelvis suggestive of genital tuberculosis. So to come to an exact diagnosis, one needs to go for laparoscopy in this situation as the next step. Now, the another figure that they also asked in your examination was this. What diagnosis comes to mind seeing the following image, guys? What diagnosis comes to mind? Now, this is the snowstorm appearance, and it is seen in a complete molar pregnancy. It is seen in a complete molar pregnancy. On the other hand, if you remember the ultrasound findings of a partial molar pregnancy, your ultrasound appearance is usually suggestive of missed abortion findings. It is often misdiagnosed as missed abortion. So you can find a fetus there, some fetal tissue might be present, and of course the cardiac activity is not going to be there, and you can find a cystic placenta also. So these findings will be suggestive of a partial mole. Snowstorm appearance is characteristic of a complete mole. In any of the situation, you have to go for evacuation of the uterus. That means you have to go for a suction and evacuation. And the contents that you will take out, you will send those contents for histopath. The contents that you remove, they will be sent for histopath, and the final diagnosis will be based on the histopath evaluation. Okay. Now, what else had they asked? This is, I feel, a controversial question which they asked this time in your FMG examination. Now, a woman is in labor and she's getting regular contractions, right? She is 5 centimeter dilated, fully effaced cervix. What stage of labor is she in? She's not in the second stage. Second stage is after full dilatation, right? She's not in the third stage. Third stage is for the delivery of placenta. Now she's either in the latent or active phase. Now there's a lot of debate about this. So yes, I would say she is in the active phase of labor. So traditionally your active phase has been defined as more than 4 centimeter dilatation. We call it as active phase, right? Now what happens in the last 10 years, what has happened is that this definition of active phase being 4 centimeter was given by this Friedman's graph. So you can see this blue graph here, which is showing the Friedman's curve. Okay, so Friedman curve says that there is a long latent phase, and then there is after a 3-4 centimeter dilatation, there is a sharp rise in the dilatation, and then it is this bell shaped curve that we see. Okay, now this blue curve is showing the Friedman curve, which is the bell-shaped curve. And according to Friedman, the active phase was when your cervix had reached a 3 to 4 centimeter dilatation here. Now this has been recently changed. It's not so recent if you look at it. Zhang et al, conducted a study in 2002, and a further modification was made in 2012 also, and they suggested that the 4 to 6 centimeter somewhere the dilatation is slow blood progressive. It is slow blood progressive. So they said that it is after 6 centimeter that the dilatation is actually very rapid. So they said that your active phase should be 6 centimeter, and this has been endorsed by ACOG as well. Yes, there's an ACOG committee opinion coming in 2016 where they recommended that your active phase should be 6 centimeter. Their active phase threshold should be 6 centimeter. Now, this has not yet been incorporated in the partogram that we are using. It has not been yet incorporated in the partogram that we are using. We still plot the partogram from 4 centimeter onwards, right? So the WHO has not revised its guidelines has not revised the partogram as of yet. But what is the latest evidence coming from WHO which I found was this. So WHO recommendation on definitions of the latent and active stages of labor, and this is a recommendation that they gave in Feb 2018. So they said that the first stage ka latent phase is a period of time characterized by painful uterine contractions, variable changes of the cervix, some degree of effacement, and slower progression of dilatation up to 4 centimeter. And they are recommending that the active stage of first stage is a period of time where there are regular painful uterine contractions like the one that is mentioned in the question, substantial degree of cervical effacement like mentioned in your question, fully effaced cervix, and a more rapid cervical dilatation from 5 centimeter until full dilatation. So therefore, I say that that particular woman which has been described in the question is in the active phase. It would have been better if they would have given a time. I'm not sure had they given a time whether this PV was done of after how many hours in labor. I mean, that would have given a clue. But yes, from what is mentioned, I will say that she is in the active phase. Now, the reason why the WHO has come up with these revised guidelines is that application of this 5 centimeter cervical dilation threshold as the benchmark for onset of active phase of first stage of labor might be cost effective because it has the potential to reduce the interventions to accelerate labor and birth. That means when I told you that those people, Zhang et al., who suggested that graph that, labor is slow between 4 to 6 centimeters, slow blood progressive between 4 to 6 centimeter. So if I allow the woman to progress in labor between 4 and 6 centimeter on her own, just watchful waiting and expectancy, right, then I reduce the chances of intervention, oxytocin stimulation, and obviously I don't take hurried decisions to perform a cesarean section. That's why they said that it should be prudent to shift the threshold for cervical dilatation as marking the active phase of labor to 5 centimeter. So that's the logic. And from my understanding of these various recommendations, so the American guidelines have their own recommendation. I mean, the RCOG, Royal College UK guidelines, they're still stuck on 3 to 5 centimeters. So they have not incorporated as of yet. But this is the latest in the line of recommendations which has come from WHO. So I would say the answer is that you should, if you've marked active phase, I think you've marked it correctly. So that's it, guys. That's for the discussion of all of these questions. And I hope that you have attempted all the questions correctly. So from what I see and what I judge this question paper pattern to be, a lot of figure-based questions, a lot of conceptual questions, nothing too difficult so far. And yes, straightforward questions. Even if they're asking you about intestinal, this hysterectomy question could have come as a surprise, or this question about the dependent portion of the pelvis could have come as a surprise as far as obs gynae is concerned. But then these can be attempted by simple understanding of anatomy as well. So please, friends, subscribe to the platform, and you can check out my previous special classes on the platform as well. If you subscribe using my referral code, that is SHONALI, you can avail a 10% discount in your subscription package as well, and then you will be able to access the various plus courses on the platform. So thank you, guys. Have a great day, and see you for your next session on YouTube. Bye bye. Take care.